Now coming to the surgical management. This is done by some cardiologists, so you don't need to know this one. That's about it. So let me tell you what you need to do from cardiology, because since we are here on the cardiology chapter, what you need to know is just some basic ECGs. Which one? Ventricular fibrillation, atrial fibrillation, ventricular tachycardia, bradycardia, SVT, then AFib. So these are the most important ones that you need to know. Then heart blocks, all of those ones, heart block 1, 2, 3, and 4. These ones are important. And along with this one here, I would suggest you to do endocarditis, rheumatic fever.
Can you repeat this list again for
Sorry.
ECG?
Okay, list for
Read
the
this list again.
Okay, list for ECG is atrial fibrillation, ventricular tachycardia, SVT, then all the heart blocks, tachycardia, bradycardia, and atrial fibrillation has been done, all the heart blocks, and I think that's it. These are the major ones that you need to know. But if you find something else, like maybe any ventricular arrhythmias or cardiac arrest, if you want to look into those ones, those are not very important ones, but you can look into those ones as well. Okay. So let me do the heart blocks from here. Just a second. Heart block. So MI is important as well. Please do MI as well. MI, like ECG wise, is important, as well as its treatment is important as well. So here, so heart blocks, as a nodal dysfunction, you can just remember this is a sinus bradycardia. That's what is happening here. So first degree AV block. So first degree AV block will only show prolonged PR interval, nothing else. There is no drop. There is nothing. Only it, like in a healthy adult, there could be frequently present. So in this condition, you are not going to do anything. No treatment required. As you can see, their PR interval is prolonged. As you can see, from here to here, it's different. And from here to here, it will keep on increasing and increasing in the further one. Then coming to the second degree AV block type 1. In this one, the PR interval is increased, along with there is one beat might be in 4. Like if you go with the 4 PQRS intervals, there will be one that will be dropped. Otherwise, no. There is basically 4 into 3 conduction. So after every 4, there might be one of that is dropped. So even in this condition, we don't do any treatment. So there's a gradual prolongation of the PR interval with the failure of the conduction of the P wave. So only one after every 4 will be dropped. Just remember this one. Then coming to the second degree AV block type 2, what happened is PR interval is dropped and there is an abrupt failure of the conduction of the P wave. So in this one, more frequent dropped waves will be there. So after every 3 or maybe after every 2, there will be one drop. So 3 into 2 ratio. PR interval is same. PR interval is constant. So what is the difference between the second degree type 1 and type 2? So type 1 has PR prolongation, but in type 2, the PR is constant. PR will not change. PR is constant, but what happens is there is an abrupt failure of conduction. So more dropped P waves or QRS intervals will be there. So every 2 to 3 ratio or 3 to 2 ratio, there is a drop of it. Now coming to 3 degree, this is basically P to P interval is same, R to R interval is same. Otherwise, PQRS will not be formed. A proper PQRS will not be formed. So wide or a narrow QRS interval, P to P wave and R to R waves are constant. In this, we do management and give electrical pacing. Even in the second degree, we refer the patient to the cardiologist and they'd go for electrical pacing. But in the first degree and the type 1, we don't do any treatment. We just do the reassurance and ask them to do the follow-up. So first degree, PR prolonged. In the second degree, PR prolonged and there is a drop of P wave. In the third is type 2. What happens is PR is constant and there is a drop of the P wave. And then in the third degree, there is no proper PQRS interval. So that's about it from the cardiology. That's what you need to do. This is just the important topic that's what I'm telling. If somebody needs to do cardiology overall, like you have time for the exam, then you can do more than that. Okay. Now coming to acne. So acne is in dermatology. Since we are in dermatology, I will let you know what you need to do from dermatology. A lot of things from dermatology is only tested based on the pictures. So whatever you are doing, just remember the pictures. That's more important than knowing anything else, like squamous cell carcinoma, basal cell carcinoma, actinic keratosis, leukoplakia, acne vulgaris, rosacea. These are important ones. And if you are doing something else, just remember keloids, because these are very important on the basis of how they look like, not what you know about them. Eczema is very, very, very important dermatitis. If you can remember and see how the picture of it look like, please do that one. All of those pictures, especially the ectopic one, contact one, these two, and seborrheic dermatitis. These are very, very common: ectopic, contact, and seborrheic dermatitis. Then tinea, all of the fungal infection, tinea corporis, tinea capitis, then athlete's foot. These ones are more important. Okay. Coming to acne vulgaris. So acne vulgaris, type 1, type 2, type 3, type 4. Type 1 is comedonal. Obviously, everything is comedonal. Then type 1 is basically having scar or no scarring. But type 2 will increase a little scarring. Type 3 will increase even more scarring. Type 4 will increase the risk of severe scarring. That's why see each and every type, how does they look like on the pictures. Okay. Site of predilation is face, neck, upper chest, and the back. Then usually in the puberty, 10 to 17 years, differential diagnosis is folliculitis. Folliculitis is very, very important as well. I forgot about that one. Then keratosis pilaris, and then perioral dermatitis and rosacea. Rosacea is important because a lot of people have been suffering from steroid use, so they might be present with the rosacea. Coming to the management of acne. Now, in the mild, it's different. In the moderate, it's different. In the mild, over the counter is different. In the mild, prescription is different. Now, over the counter, topical ones is only used. Which one are those? Benzyl peroxide and salicylic acid. Those ones should be given or should be used over the counter. As you, if why they said this is over the counter, because if somebody is coming to you with an acne, or which is worst acne, they have been already used benzyl peroxide and salicylic acid because it's available over the counter. Now you are going to start with a prescription, but if they don't mention in the scenario that they have tried anything and want you to prescribe something, then you can start with the history by knowing if they had used anything, and then can start from the benzyl peroxide. Now prescription is also being, if this is a mild one, you are going to start with the topical one. What are those? Anti Antimicrobial, retinoids, and combination therapy, where they both are used. Benzyl peroxide with the clindamycin. But what happen is, if you have to choose between which one is more effective, then combination therapy is always the most effective one than using it alone. So antimicrobial retinoids, topical retinoids can be used in the mild acne, and then combination therapy where the clindamycin and benzyl peroxide can be used as together, or clindamycin with the tretinoin can be used as together. Then coming to the moderate therapy, this one, you can use the oral one as well. So tetracycline, minocycline, doxycycline can be used. Then cyproterone acetate, ethylene, estradiol can be used, which is basically a progesterone and estrogen combination. Then spironolactone can be used in the moderate ones. Usually we go with the antibiotics, which is very common one. Do not use with the isotretinoin. So sun sensitivity can be here. Here is the caution. Use caution with that regard to the drug interaction. Do not use with isotretinoin. So isotretinoin cannot be used with the doxycycline. Antibiotics require 3 months of use before assessing the efficacy. Then severe acne, you are going to prescribe the oral isotretinoin. So you need to make sure that this person is not pregnant or about to get pregnant. and you have to do the basic baselines like lipid profile, LFTs, beta HCG before the treatment. Beta HCG is everything in this scenario. They can ask you what is the first thing or what are the main tests you would like to do before prescribing isotretinoin. Now coming on to the sidebar, acne myths debunked, like eating greasy foods can cause it, eating chocolates can cause it. No, it does not cause it. Blackheads are black because of the oxidized fatty acid. No, it's not that. It's the dirt. Acne is not caused by the poor hygiene. Then coming to the antibiotics are used in inflammatory skin condition since they have anti-inflammatory properties. Topical antibiotics may also be used to treat the secondary bacterial superinfection like subimpetigo or something, all of these ones. So you can use oral ones along with the topical ones. Acute exacerbation factors are if they are using any medication like lithium, phenytoin, steroid, and then androgens, danazole, these ones. Then coming to topical agents, this is steroid, tars, ointment, then mechanical pressures or occlusion can be cause of the acute exacerbation, then emotional stress. A combination of, here it's written, topical retinoids and topical clindamycin is more effective than either agent used alone. So combination therapy is always the answer to if they ask for the most efficient one. Intralesional injections like intralesion corticosteroid injections are effective in the treatment of the individuals with the acne nodule. Isotretinoin and the pregnancy use of isotretinoin during pregnancy is associated with a spontaneous abortion and the major defects. So pregnancy should always be ruled out with the isotretinoin use. You can skip other blood tests, but you cannot skip beta HCG. Patient should use two forms of contraception while on the isotretinoin. So two form of contraception should be used. A person who is about age where she can conceive. Okay, so this is important. So two form of contraception is everything in this scenario. Now the next thing is delirium. So delirium is also written in neurology and also in psychiatry. So let's go with the neurology one. In the neurology, let me tell you what are the most important topics that you need to do is basically optic neuritis is in important of then ophthalmology. This optic disc edema, why? Because the picture, in the picture wise, otherwise you don't need to know the treatment and all of those things, just the picture is important. Abnormalities of pupil is important. Seizures are important, how you're going to control the seizures because it's an emergency condition could be there. Status epilepticus is one of the emergency conditions, so that's why it's important. Alzheimer, Lewy bodies, if you are going to do it from psychiatry or there is a chart or table on the sidebar, even if you do that one, that's more than enough. You don't need to know the treatment, all of those things, just the Alzheimer treatment is very, very important. Then this one here, mild traumatic brain injury, as this is important in emergency medicine. Uh, Parkinson disease is important because the treatment is also important as well. It's very common. Wernicke-Korsakoff because it's involved in the alcoholic patients. If you can remember Guillain-Barré, myasthenia gravis is important and their treatment is important. Now, if you are doing myasthenia, just read the Lambert-Eaton myasthenia syndrome as well. Trigeminal neuralgia, post-herpetic neuralgia, these ones are important. Neuropathic pains are important. Um, Sleep, just remember the sleep cycle, the REM, non-REM sleep. Sleep apnea is important, very, very important. Then coming to the CNS infection, like meningitis, encephalitis, both are important. Multiple sclerosis is important. So if you could remember these ones. Now let's do dementia and delirium. So major neurodegenerative disorder, neurocognitive disorder, formerly called dementia. So usually what happened is in this condition, IDL and AIDL both are disturbed. So you need to know what is IDL and AIDL. It's mostly written in geriatrics. So if you can remember it for.
Can you tell me the page number?
The page number is, I think, just a second. I think it's 894 or something. Okay. So let's go with the. Okay, so dementia. So this is basically ADLs and IADLs. Both are important because you need to know for the geriatrics. Diagnosis of the major NCD, like neurocognitive disorders, requires a significant cognitive decline. So how you are going to assess that one? By doing the MMSC and MMOCA. So here, the most sensitive one is MMSC. It is 87% sensitive, and clinical judgment is 85% sensitive. So usually if they ask for what is a sensitive test to confirm the dementia, it's MMSC. Even if they ask for what is the short term or easily used method, is MOCA, MOCA. Then vitamin B12 deficiency can also lead towards these symptoms: macrocytic anemia, pallor, shortness of breath, fatigue, chest pain, palpitations, confusion, decreased vibration sense, and then distal numbness, weakness and upper motor neuron lesion, diarrhea, and anorexia. If somebody is using PPIs for a prolonged period of time, they can also develop vitamin B12 deficiency and can also present with that dementia. Then major neurocognitive disorder consideration for the management, starting with affective disorders like ADL, behavior problems, caretaker or cognitive medication and stimulation, the directives are driving, sensory enhancement. So these are the management that need to be done. Now coming to the history. So you are going to start with the geriatric giants. So you are going to check for the confusion. If there is an incontinence or there is any fall, history of fall, then memory and then safety, behavioral, polypharmacy and compliance. These are the history questions that you would like to ask. So in an CDM question, they can ask you what is the basic history question that you would like to ask. Now coming to ADL signs, and IADL signs, then along with cardiovascular, alcohol, smoking, collateral, and family history. So starting with the confusion, if they are taking any polypharmacy, these are more important than knowing anything else. Then once you assess what is the cause of it, then you can switch to ADL and IDADL. Then you can switch to the risk factors, what is causing it. Most common cause of the rapidly progressive neurodegenerative disorders are CJD, I think it's Creutzfeldt-Jakob something disorder, frontotemporal lobar dementia, topathies, diffuse Lewy bodies, and Alzheimer disease. The most common is Alzheimer disease. Then you are going to start with the blood pressure because patient might be suffering from the hypotension. Hearing and vision is important. It's very, very, very important because this is very common and people miss this one because maybe the hearing is the problem. That's why he's having this falls and unable to maintain the balance. Now coming to the vision is important because if the vision is disturbed, then maybe that is leading towards a fall. Neurological exam, including the Parkinson, general physical exam, will focus on CVD and then risk factors, history, MMSC, and MOCA. As I said, MOCA is very commonly used because it's very easy. Like you can ask few questions and then you can assess on the base of that. MMSC is very like a whole thorough testing you need to do. Otherwise, if they ask for sensitivity, then MMSC is more sensitive. Then clock drawing, frontal lobe testing, go and no go word testing similarities, and then proverb. Investigations obviously rule out any other cause that is causing it. If there is nothing, then you can go for dementia control itself. CBC for vitamin B12, alcohol use, then glucose, TSH, B12, RBC, folate, electrolytes, LFTs, renal function, lipids, serum calcium, CT, head, MRI because of trauma, then VDRL syphilis can lead towards its HIV, ANA, dsDNA, and CARS neuroplasm. So these can be done. Then issues to consider, failure to cope. So these are the most important ones in the CDM question. They like to test these things. If you are able to consider the factors that should be considered in the dementia. So failure to cope, maybe the patient is having anxiety, fitness to drive. If it's unfit to drive, then you have to tell the authorities. Caregiver capacity, well-being, power of autonomy or attorney, if they are able to make their living will and their medical thing. Then legal will, what are they going to do about the legal thing, like about their property and stuff. Advanced medical directives, if they are able to do DNR or all those things. Patient and the caregiver safety. So these are the things that you need to consider. Then selective causes of the major NCDs, basically Alzheimer disease, dementia, and then frontal lobe Huntington disease. Usually they can present all with the memory loss, visual disturbance. So dementia with the Lewy bodies present with the visual hallucination. Frontotemporal, I'm just telling you one of the most important thing that they can present with. Alzheimer is basically overall impairment. The age factor is important to make the diagnosis of Alzheimer. In the Lewy bodies, the visual hallucination is more important than anything else. Frontotemporal, the behavior disturbance is more. My husband is not behaving the way he was behaving before. Huntington, there is chorea. So in these ones, we are going to start with the CT-MRI, but in the Huntington, you go with the genetic testing. Coming to the vascular one, what happened is there is a features with the bradyphrenia, and there is a stepwise deterioration. Like slowly and very progressive is more common. In the vascular one, what happened is stepwise deterioration is classic, but progressive deterioration is more common. What happened is one by one, he stopped doing this. Before he was unable to do this, now he's unable to do this, now he's unable to do this. So one by one. CNS vasculitis is sign and symptoms of vasculitis. Chronic meningitis could be the cause, encephalitis and abscess could be the cause. CT-MRI could be done to confirm the diagnosis. HIV, Creutzfeldt-Jakob syndrome. So it is also rapidly progressive. If there is a myoclonus, you will do CT-MRI and EEG. Syphilis could be the cause, traumatic SLE, neoplastic, the tumors and other these ones. So the top ones are the more common one, the primary and the vascular ones. Usually, the management is obviously written in the geriatrics, but the failure to consideration are these things, and you are going to focus on these ones, providing a favorable environment where they're unable to do their things. So these ones. So early signs of major NCD and the normal aging. These ones are the forgetting the names of the close relations. This is normal. Increased frequency of forgetting and then repeating phrases. This normal. Sorry, this is not normal. Unpredictable mood changes, decreased interest in the activities. Now coming to the normal one, forgetting the names, briefly forgetting part of an experience, not putting any things properly. Mood changes is response to the appropriate causes and change in the usual interest. So this is about the dementia. Now go by delirium. I think it's written in psychiatry. Let's go to the psychiatry. So let's start with the management of the delirium. So what is the basic management? So first step first, you are going to check with the goal is to treat the underlying cause of the delirium while minimizing the physical and the psychological distress. So you can use the same management for dementia as well, because in the early stages they might be feeling the same like as in stage 1 or in stage 2, but once the diagnosis is confirmed, you are going to do the specific management according to that. So if you look into the delirium here, so a disturbance in attention should be there. Along with that, disturbance developed over a short period of time, and additional disturbance is cognition, and then disturbance in the criteria A and 2. Which one is that? In attention, and the short period of time should be there, and there is no other history of any other disease. So first rule out that evidence of history and physical examination laboratory tested that disturbance is direct physiological consequences. Now, starting with the first one, disturbance of the attention, sleep, wake cycle, psychotic like symptoms, attention, affective symptoms like anxiety, fear is there, and then shift in the psychomotor activity is the clinical features. The most common features like people will be present with the disturbed irritability, unable to sleep, unable to cope. So these are the major factors they can present up with. So here is this confusion assessment method, highly sensitive and specific, which is MMSE. Then part one assessment instrument that should be used. So what happened is part one and part two, the four features should be used. Then acute onset and acute fluctuating force is there. Inattentive, disorganized thinking and altered level of consciousness can lead towards the formation of the diagnosis of delirium. So etiology of the delirium is eye, watch, death, infection, withdrawal of any of the substance, acute metabolic disorders, trauma, CNS pathology, hypoxia, deficiencies, endocrinopathy, and acute vascular toxins and heavy metals. So these are all of the etiologies of the delirium. Now coming to the risk factors, the most important is polypharmacy. Please do not forget about this one. Then forget all of these things can be there. Hospital nursing resident incident is 60%, and old age is also cause. Starting with the assessment, how you're going to start with the obviously history and physical examination is one of the most important thing. You're going to start with the history, asking question if they are reliable and unable to answer them or able to answer them. So basis on that, then such as the confusion assessment method, these are the things that you are going to do. Then bedside test to assess for the tension, memory, and the visual, spatial, and executive function and the orientation. So let me tell you, the delirium and dementia is very, very important, and they love to test this in the exam. So blood work, CBC differentiates electrolyte, glucose, B1, creatinine, TSH, T4, LFTs, B12, folate, albumin. So these are the things. Then coming to the standard testing, chest X-ray and CT scan is done to confirm any other underlying cause. MRI can be used, then standard urine analysis, urine dips test is done. If indicated, lumbar puncture and EEG is used. Coming to the goal is to treat the underlying cause of the delirium while minimizing the physical and psychological distress. Same goes for dementia. You can start with identify and manage the underlying cause. Identify and treat underlying cause immediately if the possible. Stop all non-essential medications like polypharmacy is there, so you have to look into that one. Then maintain nutrition because lack of eating can also cause the delirium. So nutrition, hydration, dehydration can also lead towards the electrolyte imbalance, especially potassium and sodium can cause this. Monitor vitals. Then work to ensure the regular bowel movements. Constipation can also lead toward this one, and skin care practices to prevent the pressure ulcers. Maybe having a bread sore, which leads towards the sepsis, and sepsis lead towards the septic shock, leading towards the delirium. Optimize the environment. This is important because this optimization is also going to be done in dementia, because a lot of people are irritable in those conditions as well. So what is the thing? Environment, keep quiet, well lit near window for the cues regarding the time of the day. Then optimize hearing and vision, room near nursing station for the closer observation, and constant care is needed. Family member present. If for the reassurance and reorientation, then check for the calendar, clock, and reminders for their specific orientation again and again. Avoid the frequent change or assigned nursing staff because it can cause irritability. Implement fall prevention like giving a stick or a railing to enable the safe mobility. Then physical restrainment to maintain the safety. Calm and sportive approach and therapeutic communication is important. Coming to the pharmacotherapy, antipsychotics as in haloperidol is most evident because it can prevent with the psychiatric condition if this is having any kind of psychiatric hallucinations. Alternative include the risperidone can be used. Caution all neuroleptic prolong the QT interval in the old people. So it's more important to see. And along with that, if the person has a history of seizures, it should not be used. Thus, including the risk factors. So you are going to check two things. What are those ones? First is seizure, and second is heart condition before prescribing any of the antipsychotic like haloperidol or risperidone. Then EEG or ECG is done to check for the QT interval. Benzodiazepines are can also use because they are sedatives and can induce the sleep. Try to minimize the drug with anticholinergic effects. Note antipsychotic medications are used in the delirium to treat the SOER patient agitation. Holding down with the physical restraints only done if the person is trying to harm you. And then if you are unable to control that person with a medication. First thing is medication and then physical restraint. But if you think that the danger is more and unable to control with a medication, then physical restraints. Now coming to the family medicine. If we go by family medicine, I think everything is important because in a family medicine, everything is being tested. So if you can just go with the basic things in the family medicine, I think that would be also good enough. Like what are the basic investigation you are going to do in the family medicine, those are more important than doing anything else. Counseling is more important than doing anything else, right? So whatever topic you are doing, just make sure you know the basic investigation, you know the basic counseling of each and every disease. So the table here, periodic health exam. So general population, we do dental hygiene in everyone. We go for the counseling of smoking in everyone who is smoking. Noise control is important since scene of poverty. So this A and B shows A is the thing that is must be done in everyone. B is like in the moderate quantity, and then C in the very like mild if it's needed and if it's not needed, right? So A is like something which is done in every single population. So dental hygiene should be discussed with every single population. Noise control and hearing protection should be discussed with every old age. Then seen a screen for poverty, as I said, not everyone is poor. Then counsel on screening cessation or smoking cessation as in first hand and tech contact or as in second hand contact. Provide nicotine referral to the smoking cessation. Not everyone needs smoking cessation counseling referral. Then dietary advice on the leafy vegetables and fruits, because if somebody need it and if somebody doesn't need it. And seat belt use, moderate physical activity, wearing the sun exposure, avoid the sun exposure, and wearing protective clothing. Drinking screening and counseling, STI screening and protection. Then nutrition counseling and dietary advice, and cholesterol and vitamin D supplementation should be discussed with every single population. Now, based on the type of population, like in pediatrics, you are going to discuss the home visits. If they are suffering from any child abuse or those things, then injury prevention and inquiry into the developmental milestones. Then coming to the adolescents, counsel on the sexual activity should be discussed, and then contraception. It should be discussed in everyone, but not in each condition. Counsel to protect about the smoking cessation and substance use. If somebody is willing to talk about it, then definitely you're going to do, but not in every condition. Then perimenopausal, you are going to discuss with osteoporosis and fracture. It's usually discussed with everyone, and it's common in guidelines to discuss these ones. Then counsel on the osteoporosis and counsel on the risk factors of the hormonal replacement therapy. If there is a risk factors of that, then you are going to discuss that one. Then adult more than 65, follow up with the caregiver if there is any abuse going on, those things. And multidisciplinary post fall, because in the delirium and dementia is very common. Pediatrics, you are going to discuss for the examination of hips, eyes, and earring in the every single one. Then height, weight, and head circumference is not done in everyone. If there is a family history, then visual acuity assessment is done, testing after age of 2. Physical, like a question can be asked in the newborn, how you are going to check the vision. So if you can find out what is the answer to that. Physical blood pressure measurements using technique described in CHEP, and then height, weight, and calculate BMI for the adults. Now, if the adult is more than 65, hearing impairment should be discussed, not in everyone if there is any problem. What is the one test you would like to check the hearing replay assessment in the hearing impairment in the 85? It's basically whisper voice test more than anything else. So starting with this one. First degree relative with the melanoma, so you're going to the full body examination. As you can see, high A is the high quality evidence and B is the moderate quality evidence. Now coming to general population, the test is going to be age, basic, and specific gender basic. Then screening for the diabetes, dyslipidemia, hypertension, screening on cancer screening, one time screening ultrasound for the abdominal aortic aneurysm in the men age 65 to 80 years. Then special population pediatrics, TB high risk factors, and then STI risk factors. Pediatrics routine hemoglobin for the high risk infants, and then blood-led screening of the high-risk infants. TB, Montauk's test should be done in everyone, especially in the indigenous population. STIs, voluntary HIV antibody screening should be done. Then syphilis, high-risk group should be done. Test it should be done with the VDRL1. Then coming to the therapy, folic acid in the childbearing is given in everyone. Pharmacological treatment of HTN should be given to all of those people who has HTN. Risk factors, varicella vaccination should be discussed in everyone who is susceptible, especially in the indigenous population. Rubella should be discussed with everyone, especially in the non-pregnant woman, because you don't give live vaccination in the pregnant one. Tetanus routine booster pertussis less than 65. Tdap and tetanus should be discussed with everyone, especially in the pregnant female. Then herpes zoster vaccination after the age of 60, like more than 50 years. Then pediatric population routine immunization should be discussed in every single one. It's up to them if they want it or not. Your discussion or your counseling is important in everyone. Influenza outreach strategies for the vaccination and annual immunization, HPV risk factors, vaccination for the male and a female from the age 9 with the no routine age limit, TB and isoniazid prophylaxis for the household can be discussed if they want to take the treatment, right? Then immunocompromised 65, more than 65, COPD, asthma, CHF. In those ones, you are going to ask them to get the pneumococcal vaccination, and it's highly risk population. You are going to ask them. It's very high evidence, so you are going to tell them to do it in every cases. Now, if you go by screening, what is important in screening? The age, it's done in 50 to 74. What is going to be done? Mammography. How often? 2 to 3 years. And when are you going to discuss based on the benefits? So this is everything that you need to know. The age 50 to 74. If you make a small page and put it in front of your face and keep on memorizing in every day you will not forget it. But remember this, these kind of stupid questions is being asked in MCQs, because in MCQs there is less time, and if you don't remember these numbers, the age, the how frequently it's been done, you will spend a lot of time thinking and those things, so it will cause problem for you in MCQs. In a CDM, you can definitely write down and think a lot. You have enough time, right? So 50 to 74, mammography should be done every 2 to 3 years. So self-examination should be prohibited. They cannot do self-examination. Mammography is not only done only like in not done in 40 to 49 year of the age, and MRI cannot be used, and then self-practice should not be advised. So it should be prohibited. Now coming to the lung cancer, same age factor 52, 55 to 74 years, more than 30 pack year smoking history. So not every single population will be tested for lung cancer. Only those people which has a smoking history. It's important. Why? Because people think that each and every person should be tested for lung cancer. No, only those person who has history of smoking cancer, smoking like more than 30 pack per year, who are currently smoke, or who quit smoking less than 15 years but have been smoking more than 30 pack. Okay, in those conditions. And what are you going to do is basically LDCT, and how often? 3 consecutive times. Like if you done it one time, after next year you did it again, in the next year you did it again, in the 3 consecutive, like in the 3 same years, in the 3 same upcoming years it's negative, then you are going to stop it. If even in the one time you find some suspicious nodule, you are going to keep on doing LDCT. Please, this lung cancer is very very important, because on the basis of this 30 pack smoking history, they can give you, if somebody is doing a 15 pack smoking history per year and ask you if you are going to do it or not, so on the basis of that you are going to calculate it and see if this is more than 30 pack, and who is currently smoking, or who has quit smoking less than 15 years back, and it should be done after 55 years, and 3 consecutive times it should come out negative. These are the magical words that can help you to do this lung cancer screening is required or not. It's important. This is very 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 important. Please remember this on fingertips, this lung cancer. Because lung cancer and then chest x-ray is not used, so don't miss this one. For all other adults, regardless of the age, smoking history or other factors, recommend not screening. Whatever so happened, you are not going to ask them. If this patient is in contact with a second hand smoking, like somebody in this friend zone is smoking, you are not going to ask them to go with the lung cancer screening.